Okay. Thank you for your patience to coming to tonight's the ICC webinar. I'm so happy to have all you here with us. So good morning and good evenings. I'm Dr. P.Y. Cho and my colleague Dr. Junior Tu. We both will moderate this webinar together. And welcome again to ICC webinar today. Today, we are so honored to learn from Professor Hsueh-Yu Lee's presentation. Professor Lee completed his research fellowship in Royal Infirmary, Edinburgh, United Kingdom. And Professor Lee has been as the president of Taiwan Society of Sleep Medicine and the president of the Taiwan Voice Society. Professor Lee focused himself on obstructive sleep apnea, and Professor Lee has numerous academic publications and chapters and textbooks in the field of sleep medicine. As well as Professor Lee won the Stanford University top 2% scientist in the world from the year 2020, 21, 22 in the Lifetime Achievers. Today, our topic is the obstructive sleep apnea, myth in the diagnosis and the treatment. And we have three very well-known experts invited to the panel. And I would like to invite our co-moderator prior to introduce our very important key panelists as well. So please, prior.
Hi everyone, so happy to see those of you today. Today we will have three panelists to join us in this session. The first one is Professor Deb Singh. Professor Deb obtained three doctorates, including Doctors of Dental Medicine, a PhD in Craniofacial Cap Pilots and Development, and a doctorate in Orthodontics. Professor Deb is honorarily diplomats of the American Sleep and Breathing Associations and the members of World Sleep Society. Currently, Professor Deb is an adjunct professor in sleep medicine at Stanford University, USA. And the second panelist is Professor Susanna Falado. She is the president of the European Academy of Dental Sleep Medicine and also a vice president scientific committees of American Academies of Dental Sleep Medicine. Moreover, Professor Susanna is the assistant invited professor of orthodontics, public health, and also sleep medicine at Portuguese Catholic University. And the third panelist is Professor Wish Banhiran. Professor Wish obtained 4 fellowships from the U.S., include a fellowship in rhinology from Universities of Miami, a fellowship in pediatric sleep medicine from Tulane University, a fellowship in otolaryngology from Harvard University, and also Professor Wish was the first person from Southeast Asia who attained a fellowship in sleep medicine and surgery from Stanford University. And Professor Wish also achieved a certificate from American Board of Sleep Medicine. Currently, Professor Wish serves as the chairperson of Otolaryngology Associations of Thailand, and he's the head of Sleep Medicine Division, Departments of ENT Siras Hospital from Thailand. And now it's time for Professor Lee's presentation on the topics of obstructive sleep apnea, myth in the diagnosis and treatment. And welcome, Professor Lee.
Oh, thank you. Thank you for the very kind introduction. Dear friends, it's my pleasure to give a talk in this webinar. The issue I would like to share today is obstructive sleep apnea, the myth in the diagnosis and the treatment. So this is our outline for today. Firstly, why we need to talk about the OSA, the importance. I would like to share you the importance in terms of the prevalence and OSA causing complications. The second, myth in snoring, is the snoring harmless or harmful? The third, myth in pathogenesis of OSA, is OSA a neurogenic disease or anatomic disease? The fourth, myth in the diagnosis of OSA, we can discuss from standard polysomnography to home sleep apnea test, from prevalence stage to drug-induced sleep endoscope. The fifth, myth in the treatment of OSA, we can introduce the traditional excision to our innovation, functional reconstruction. Finally, we can discuss the essence of the treatment, from sleep apnea surgery to preventive medicine and holistic care. So the obstructive sleep apnea, the importance is a high prevalence disease. In Taiwan, it's about 1 million symptomatic OSA patients. It's around 5 times larger than patients of hearing impairment. And the global prevalence is here. So it's a high prevalent disease. And OSA is not only a respiratory disorder, but a systemic disease. OSA can cause cardiovascular consequence, metabolic syndrome, neurocognitive behavior disorder, Alzheimer's disease, even death. So no matter which professionalism you are, we are all facing the enormous challenge from OSA. OSA is not only a medical issue, but an economic issue. From one report, the estimated economic loss of OSA was nearly 150 billion. So it can cause a huge economic loss. It's not merely a medical issue. Let's talk about the snoring and the obstructive sleep apnea OSA. The difference between the two, snoring is to describe a tissue vibration. OSA is to indicate an airway obstruction. So the snoring will cause, we call it acoustic trauma by the vibration. And the OSA, due to the obstruction, will induce the hypoxia and fragmented sleep. So the treatment for the snoring is non-invasive oral appliance or invasive surgery, or the patient with daytime sleepiness, we use the CPAP. For OSA, CPAP is always the first-line treatment. Oral appliance is an alternative, and a surgery is a salvage treatment. Is OSA just an annoying sound, or the OSA will cause intrinsic damage? Snoring that will cause disturbance to sleep partner in 1/4 of companions, and cause the sleep partner to sleep in separate room in 1/5 of couples. So it's actually an annoying sound, but because of the because of the acoustic trauma to the hearing and the balance system. So the snoring will also cause induce the vertigo, hearing loss, and the tinnitus because of the acoustic trauma. So it will cause intrinsic damage. Snoring, the effect, we can discuss three domains: the loudness, frequency, and the index. For loudness, that's patient and the family concern the loudness. And loudness is the most important treatment outcome for the patients and the family. For frequency, it's related to patient's health because moderate and high frequency will cause acoustic trauma to the carotid artery and induce atherosclerosis. So the frequency is related to the health. But the index, the snoring episode, that's commonly used in scientific report. When we present a paper, and we usually say the surgery decreased the snoring index. That's is very commonly used in scientific report. But the patient and their family, they concern more about the loudness. And for the patient's health, is closely related to the pitch, especially in the moderate and the high pitch. Then we can probe into the pathophysiology of the OSA. We usually are trying to classify the OSA's patient as genotype, endotype, or phenotype. For the gene for the OSA can be divided into related to the obesity gene, craniofacial gene, and the respiratory control gene. So you can see the very different gene. So we cannot find one single gene to represent the OSA. So gene therapy from the genotype is not available now. For endotype, we can use the loop gain, the arousal, or the collapsibility to classify the OSA's patients from different genotype. So the different genotype for the high loop, the high arousal, a very low arousal threshold, or a very high collapsibility. So we can use the very different pharmacotherapy, the different medication to treat the different endotype, or use the CPAP to cover the endotype. For phenotype, it's more clear for the sleep surgeon because the different phenotype in obesity, craniofacial restriction, or soft tissue hypertrophy, they will be very apparent for surgeon to treat them by surgery using bariatric surgery, craniofacial reconstruction, or soft tissue surgery. So the phenotype is more suitable for sleep surgeon to have the surgical plan, but also for dentists to use the oral appliance. The phenotype, as you can see, soft tissue hypertrophy, retrogonesia, or obesity is very common in our OSA's patient, but we need to know the individual phenotypes in terms of soft tissue hypertrophy, craniofacial deficiency, or morbid obesity, they do not conflict each other, but different proportion in different patients. So in one single patient, he or she may have retrogenesia and tonsillar hypertrophy and obesity together. So just with different proportion, but they do not conflict each other. So you can find one patient, he or she has the soft tissue hypertrophy, the retrogenesia, and obesity. They will be much complex for sleep surgeon to treat. For the treatment, we can have non-invasive treatment and invasive treatment. The non-invasive treatment, the mainstream include CPAP, oral appliance, and invasive treatment indicated surgery. Non-invasive or invasive, we need to do the shared decision making. However, non-invasive treatment always precede invasive surgery, and the CPAP is always the first-line treatment, and the surgery as an alternative or salvage treatment. The surgery can be divided into the soft tissue surgery, the intrapharyngeal surgery, or extrapharyngeal surgery like bone surgery like MMA, or bariatric surgery include bypass surgery or gastric sleeving. The intrapharyngeal surgery and the extrapharyngeal surgery, now in Chang, we can perform simultaneously as a combined surgery to treat the patients in one time. For diagnosis, the difficulty in the diagnosis of sleep apnea is the daytime examination cannot predict nocturnal disease severity. So the diagnosis also, we can use the standard polysomnography and the home sleep test. The difference is the polysomnography is a gold standard diagnosis also, and other sleep disorders. Home sleep test is an alternative diagnosis in exclusive OSAs. Home sleep test can only diagnose sleep apnea, but not other sleep disorders. Polysomnography may overestimate the severity of OSA from pure supine sleep. By contrast, home sleep test may underestimate the severity of OSA from recording time instead of sleep time. For home sleep test, we can have two kinds of home sleep test, the with flow or without flow. The name apnea, link, and cardiopulmonary coping. The difference is cardiopulmonary coping can estimate the sleep quality and could be more comfortable to patients. For the concept innovations, when we try to treat the patients, should we use the anatomic stage or severity stage? By In other words, is to use the Freiman stage or AHI stage. And in our report, we found that anatomical staging is more reliable than severity staging in outcome prediction of UPVP. So anatomical based stage is more reliable to predict the UPVP outcome instead of the disease severity stage. So we have three impact to the sleep medicine in patient selection, outcome prediction, and the treatment model. Assessment of the OSA, especially in the obstruction site, is in awake or in drug-induced sleep. So this is a very common used drug-induced sleep to check, to know the obstruction of the airway. So we can have the classification as an M-mode system. The nasal valve collapse, the vitropharynx, the soft part collapse, the tongue collapse, and the epiglottis collapse, and the oropharyngeal lateral wall. So it's a M-mode system. When we compare the awake status examination to the drug-induced sleep endoscope DICE, we found a very different collapse in two sites, tongue and the epiglottis. So the awake Freiman stage cannot predict the tongue and the epiglottis collapse. And DICE will be more precisely for sleep surgeon for the decision-making of sleep position. Should we use the DICE as a diagnosis or intervention? Besides to assess the obstruction site in lateral pharyngeal wall, in Whelan, but we can do more for the DICE. For example, when you perform the DICE, we do the jaw thrust, so we can detect the effectiveness of oral appliance. When we blow the air, and we can know the titration pressure. When we change position for the patient, we can testify the effectiveness of positional therapy. When we close the mouth by mouth tapping, we can check the effectiveness of the mouth tapping. And when we suspend the soft palate or suspend the tongue during DICE, we can testify the surgical effect of palate surgery and the tongue surgery. So besides the observation, besides the diagnosis of obstruction site, DICE can do more in intervention to testify the effectiveness of oral appliance, CPAP titration pressure, positional therapy, mouth tapping, or palate and tongue surgery. So now we do the interventional DICE. For the nose, in the past time, the key element for CPAP compliance is mask. But now, from our report, we found that nasal air space is related to CPAP compliance. So this result from this result, we can make a comment is when we prescribe a CPAP for the patients, you need to ask the patients whether or not they have nasal obstruction or mouth breathing. If the answer is positive, we need to treat the nose to improve the nasal obstruction so as to improve the CPAP compliance. In the past time, the traditional nasal surgery, we excise the nasal terminate radically. But this procedure will cause serious complication like bleeding or very troublesome empty nose syndrome. So we propose a new surgical technique called a minimal invasive septal terminoplasty, MIST. We just a relocation instead of excisional terminate. It's an outfracture, not an excision. We do some transseptal suture and adjustment for the septum and the drainage. So in these procedures, there were no septal hematoma and no empty nose. So MIST can effectively enlarge nasal passage. However, at the same time, maintain nasal physiological function in terms of humidification, filter, and warming. So MIST. The result of MIST, subjective or objective. From our report, nasal surgery improved nasal obstruction, reduced snoring, and improved daytime sleepiness and the quality of life, but not HI. For those patients, they can get the benefits of nasal surgery in snoring is a small tonsil size patients. Those patients, they can get the benefits in the reduction of HI from nasal surgery is low tongue-based patients. So now we have a comprehensive viewpoint of nasal surgery to understand the result of nasal surgery for obstructive sleep apnea in subjective symptom, but not objective AHI data. The parted section, the concept innovation. In the past time, we thought snoring was generated only by soft palate. But from our research, we found that the different organ can generate different pitch snoring. For example, the soft palate, they can generate low pitch snoring. For tonsil and the epiglottis, they can generate middle pitch. For tongue, they will generate high pitch snoring. So the different organ generate different pitch snoring. So we can do the logosonic recognition and make it a visualization as a snore map, low pitch, middle pitch, and a high pitch. So they can give the sleep surgeon a very good idea how to treat the snoring in what position. So local sonic recognition, and the snore map. The traditional surgery for the snoring and the sleep apnea is to make excision of soft palate. We call it to excise so-called redundant mucosa. But it's pretty bad to do the Simon's procedure because it will cause extremely painful and post-operative bleeding and hypernasality and nasal regurgitation and a persistent lumping throat, foreign body sensation. So that's from the traditional UPBP. So we propose a new technique called a tissue-specific functional reconstruction. It means we preserve the mucosa. We abrade the fat adipose tissue. For muscle, we do the relocation in the lateral pharyngeal wall, suspension in the soft palate. For tonsil, we do excision. So it's a tissue-specific functional reconstruction. So you can see the demonstration of palate suspension. We did not excise the soft palate, but just do the suspension. So we put the mucosa preservation, fat, supratonsia fat, abrasion, and muscle suspension relocation, tonsil excision. We put these four techniques together and propose a palate hybrid surgery. So it just reinterpret UPBP, traditional UPBP, and the palate hybrid surgery can effectively enlarge the velar-pharyngeal space. In the same time, maintain the normal swallowing and the phonation. Tongue, the concept innovation. In the past time, when we say, oh, the patient has tongue obstruction, we just indicate the tongue-based obstruction. But from a serious image study, we can demonstrate the tongue obstruction emerge in various positions. The 1/3 in the tongue base, but 1/3 in the tongue body, and 1/3 in the total tongue. It means tongue body first, then tongue base. So the very different various tongue obstruction in OSAS patients. So these various tongue obstruction just can explain why we do the tongue-based surgery cannot achieve a high successful rate because for the tongue body obstruction, you do tongue-based surgery, it will make things worse. For total tongue obstruction, you do tongue-based surgery, it's a suboptimal treatment. So it's a very, very, very significant concept innovation. The traditional tongue surgery is to do the excision of the tongue base. It will cause extremely painful and a low success rate and massive, sometimes mass bleeding, swallow disturbance, and taste disturbance. So we propose a new technique. We call it a whole tongue treatment. We use a collaboration under endoscope to do lingual tonsillotomy, plus a collaboration to do the tongue abrasion to make it more strong or more tight. So it's a tissue volume reduction and the stabilization. The whole tongue treatment can effectively enlarge the retroglossal air space. At the same time, maintain the normal swallowing, articulation, and the taste. So the whole tongue treatment. For the tongue-based surgery, should we use a robotic or non-robotic? So it's a robotic and the non-robotic cooperation. In my clinic, when the patient had lingual tonsil hypertrophy, a huge lingual tonsil hypertrophy, size 3 or 4, I will do the robotic surgery. For a relative small lingual tonsil hypertrophy, grade 2 or 3, I use the low cooperation to abrade the lingual tonsil. So that's my principle for tongue-based surgery, robotic or non-robotic. The fourth site, the epiglottis. Epiglottis, we need to check the length and the angle. From our report, epiglottis length is highly sensitive in predicting epiglottis collapse with cutoff point of 16.6 millimeter. So when the epiglottis of more than 16 millimeter is very sensitive for the tongue epiglottis collapse and the total collapse. And the epiglottis angle still play a role. When the angle is of more than 40 degrees, it can cause partial obstruction, partial epiglottic collapse. For epiglottic surgery, we propose a new surgery, collaboration assisted partial epiglottic technique, CAPE. So it's a incision, incision, and incision by the collaboration. So the before and after, before and after. So by the use of collaboration, decrease the postoperative pain and adhesion. For combined surgery, intrapharyngeal surgery, bone surgery, or bariatric surgery. Now we propose the combined surgery. When morbid obesity OSAS patients, we can do the bariatric surgery plus the airway surgery, like a combined airway and the bariatric surgery. It's a Boston transdisciplinary sleep surgery. The results show CAPS, combined airway and bariatric surgery, achieve 90% success and 60% cure of OSA in morbid obese OSAS patients. Another combined surgery is when a patient has soft tissue hypertrophy and retrognathia. We can do multi-level airway surgery plus the genioplasty. So it's a combined intra and extrapharyngeal surgery. We call it a KISS. Besides the combined surgery, we needed to do some integrated treatment, like keep the patient's mouth closed by mouth tapping, especially in mild ulcer or state post-operation, but not in infant or elderly patients. As you can see, the AHI improved 50% in mild ulcer patients after mouth tapping. Also, the Snow index. Position therapy. In position-dependent patients, it means supine AHI of more than 2 times of non-supine AHI. In position-dependent patients, mild and to moderate non-obese patients, we can use the positional therapy to have some effect. And for patient state post UBBP, usually they will shift non-position dependent to position dependent. So positional therapy is good and helpful for this patient as a complementary therapy. Myofunctional therapy. In one systemic review, myofunctional therapy decreased AHI by 50% in adults and 62% in children. But we need to know the patient selection was used in mild to moderate, non-obese, no severe patients, no obese patient. They can get some more effective for myofunctional therapy. Weight loss is a general principle to know the effect of body weight reduction 10% to achieve a 26% of AHI reduction. So the 20% of body weight reduction can achieve more than 50% of AHI reduction. So there is a very hard issue to use GPT-1, the body weight reduction to get improvement in the ulcer. For the pharmacotherapy, there's 3 kinds of the medicine to treat the ulcer. To treat the muscle tone, we use the non-adrenergic plus the anti-muscarinic, but the effect is positive but modest. And for some very low arousal threshold, we can use trazodone. For the high loop gain or central sleep apnea, we can use the acetazolamide. So a common name is Diamox. So this pharmacotherapy can be effective in selected patients, but it cannot replace the mainstream treatment modality such as CPAP, surgery, or oral appliance. For those patients, they receive CPAP surgery, but with profound stiffness. Provigil, or now the new drug Wakix, could be helpful. For Comisa patients, Dora or Devico could be used in selected patients with some effect. So that's the pharmacotherapy for ulcer. Besides these issues, when we treat the ulcer, we can extend the surgical indication not only to prevent the cardiovascular events, but in children, we can improve the ADHD. In elderly, we can improve Alzheimer's disease. So treating pediatric ulcers improve ADHD. Besides ADHD, for adenotonsillectomy can improve the OSAS patients with underweight to normal weight, and to prevent some malocclusion in pediatric OSAS patients by surgery in terms of adenotonsillectomy. Treating elderly OSAS patients improve Alzheimer's disease. So OSAS patients have 2 times of incidence in the Alzheimer's disease. The treatment of OSAS can reduce 3/4 patients to suffer from Alzheimer's disease. So for Alzheimer's disease, prevention is better than treatment. And control of OSA is one important ring. For the elderly OSAS patient, we can improve the Alzheimer's disease and another issue in nocturia. For pregnant OSAS patient, when we give them the CPAP, so we can improve gestational hypertension and preeclampsia. So I would like to make a summary of my speech today. Traditional surgery for soft tissue using excision, but we propose a tissue-specific functional reconstruction, like parted hybrid surgery, whole tongue surgery, logosonic recognition of snoring, and combined airway and bariatric surgery. So this concept and technique just give the evolution in sleep surgery. So when we talk about the obstructive sleep apnea, the surgical treatment, our effort just from tradition to innovation, from classical to classical. So the sleep surgery now is not only an airway surgery, but preventive medicine and holistic care. That's my speech. I thank you very much for your attention.
Thank you so much, Professor Lee, for the very comprehensive lecture on obstructive sleep apnea, and also for sharing with us innovative concept and management for this matter. So at this time, I would like to invite our first panelist, Professor Susana Filardo, for some comments.
Thank you so much. First, let me welcome and congratulate the speaker for the outstanding lecture. Yeah, you mentioned a lot of actually novel approach to the obstructive sleep apnea. Still, it's beside a very common disease, a multidisciplinary approach, not only on diagnosed, but also on treatment. And I think that it's the major difficulty for all of us that are on sleep medicine, trying to connect everyone expertise in order to have great outcomes and to give quality of life for our patients. About your lecture, there's not so much to say because you did pinpoint every single different points and strategies for approach. I think for the common clinicians or for the ones that are starting, maybe the doubts will be where and when and how do I start to improve, to apply the diagnosis, to do the multidisciplinary treatment to one of the patients that I could have on my appointments. So I think that it's still the major difficulty for all the clinicians that are now starting, and also for the ones that are continue to continue the road on sleep medicine. is the diagnose, and then the multidisciplinary approach, and then adherence and compliance of the patients to the therapy. But well, at this point, it's what I have to say. Thank you.
Thank you so much, Professor Susanna. And the next, I would like to invite Professor Rich to share your thoughts on this presentation.
Okay, thank you very much. And I always appreciate Dr. Lee presentation. Every time I listen to his lecture, I have a good and new idea coming to my practice. So for in Thailand, I have some minor difference between Taiwan and Thailand. The name pretty much similar, right? Many people confuse that. So can I share my slide on how different I may approach the patient? Can you allow me to share, please?
Yes, please.
Excuse me. Can you see my slide? Can you see my slide?
Yes, so
Yes, now we
Okay.
can.
Okay. So in Thailand, when we see the patient snoring or suspicious of sleep apnea, we have to make a risk assessment. If patient low risk, we do the comprehensive multi-dimensional evaluation and then decide the treatment whether lifestyle or minimally invasive or oral plans. So in my country, we have proposed minimally invasive. It's not just radio frequency, probably new like a erbium yak laser and other kind of treatment. But if even low risk, if we consider patient have some benefit from sleep test or have other issue, we might send them to sleep test. But for high risk, of course, we go to sleep test, either full polysomnography or home sleep test. But in Thailand, we have different kind of sleep tests. We do polysomnography at home as well, like a type 2 level 2 or type 2 at home, full PSG at home with telemedicine. Now they use like AI and telemedicine online. And for home, we also use watchpad or ring that can use more easy for a patient. And if patient have sleep test, we consider multi-dimensional evaluation. We not consider only CPAP as a first line treatment. We not always, because we think many people like if we take a look at HI only, it might not represent all everything about the sleep apnea. I can share you how we think about that. So we treat either PAP therapy or lifestyle modification, but we can go through non-PAP therapy with lifestyle modification and have upper area investigation for that. So we can use oral plans, surgical or minimally invasive. But if we can combine together in case that patient not success with just only one treatment, that's the idea. But how to consider the parameter for treatment planning. This is excuse me. We do like a multi-dimensional evaluation, like a patient factor, disease factor, and treatment factors. It's quite similar concept to Dr. Lee, but we do like a disease factor. We take a look at we not now do a genetic genotype because it's probably too deep, but we do palm theory and PSG phenotype, and we do evaluate anatomical factors. And patient factor have clinical phenotype similar to Dr. Lee said, but we also concern their lifestyle. And the treatment factor, they have like a patient and physician expertise and facility. So like a palm, we it's hard to direct palm, but we take a look into PSG parameter. The PSG parameter will help us assess what the major component, like we do apnea hypopnea ratio. If patient have a lot of apnea, a lot of hypopnea, but very few apnea, patient probably have a poor low arousal threshold. But if patient have a lot of apnea and use a high PAP therapy, we might have consider them as anatomical factor, and other like this slide show is too long. So polysomnography, if we take a look at HI or RDI, is not enough. I think we have to differentiate, because similar HI for male and female, and the saturation index is also important, and proportion of central and mixed apnea, or even hypoventilation in very obese. So these are our idea. And for upper area assessment, we do like a Novotel, like nose, nasopharynx, word classification, quite similar, but we extend to nose and nasopharynx and larynx. So we consider the pattern, degree, and component and plan of treatment. So that's like the idea is not, I think it's quite similar for the concept, but like a minor techniques for evaluation of patient. That's that. And we take a look all of these component to like in Europe, they use like I heard that Baveno classification, but and this is like a purpose. I think severity classified by HI only is not enough, because HI have a different kind of definition, and have like a just one night, and many people have a split night study. The patient not sleep well, have a lot of arousal in sleep lab, but not arousal at home. So probably fall positive, or overestimate or underestimate, like Dr. Lee says. So we do only assess all of this and take a look into which one should proper treatment for any treatment. So that's our idea. But other is like pretty much similar to Dr. Lee. Thank you. Stop sharing.
Thank you so much, Professor Pahiran, for your sharing. And next, I'd like to invite Professor Dave Singh.
Good morning. Good morning, Wish.
Hi. Hello, Professor.
Hello, good morning.
Hi, would you like to comment on your thoughts on the treatment and management for the OSA conditions?
Could you repeat the question?
Would you like to comment on your thoughts on the management and treatment for OSA conditions?
Oh, yes, excellent. Well, thank you so much for this wonderful webinar. It's been very interesting. I think there's a lot of diversity in this field, and many people have different approaches. And so I think to myself, how am I going to start with the overall management plan? And to be honest, I start with pre-screening to say that, because the people with comorbidities that you may miss for some reason. So typically pre-screening to say, are we in the right kind of region to be able to diagnose this patient? And then from there, go on to screening. And screening, as you know, has got lots of different kind of methodologies, including things like questionnaires. Once we have the screening done to say that there's a low risk, a medium risk, or a high risk of sleep apnea, then we go on to diagnostic testing. And that, of course, is both, I would say, both systemic and craniofacial. And what I mean by that is, you can look at the whole body experience in terms of a sleep study, whether it's a home sleep apnea test, whether it's a PSG, any of those factors, but also to say, what are the contributing factors from a craniofacial point of view? So let me just take a step back, because what we find also in the pre-screening and screening is that there's a lot of technology, wearable technologies that are becoming available. Some of this stuff is over the counter, so these patients already have done maybe, you know, their own tracking with an app on their cell phone or with a smart watch or something like that. And so when we get to the actual diagnostic phase, you know, with a sleep test, we have a good idea in terms of, you know, where we're going with this. From the craniofacial point of view, specifically, I'm looking for three things. What is the site of the obstruction? What is the severity of the obstruction? And number three is, what are the factors which are contributing towards collapse, airway collapse? So again, I'm being very generic here. I'm sorry I came to the webinar a little bit late. And then once we have an idea of what it is that we're trying to do, the key, as you probably know, is customization. It's all about case selection. Which technique, which protocol which will suit which patient. And that is a bit like rolling the dice, because we really have to know, you know, have an idea of what will be the outcome of this case before we start. This is, you know, surgical planning or treatment planning. And in fact, we can now start using new technologies to say we can do virtual surgical planning, we can use non-surgical virtual planning, and then we add in new information such as AI to say we treated 100 patients with this specific technique and we got this outcome. Therefore, if we add a new patient to this mix, what would the model suggest? Will it be a surgical case? Will it be a multidisciplinary case where we're doing, you know, different modalities of treatment? Is this case where you have, you know, obesity, for example, and so we have to look at that in terms of overall management, systemic management, before we go to a specific treatment for, you know, a localized obstruction, let's say something like that. So the thing about management, as you know, is a progressive field. So we started with standard CPAP, which is wonderful, but now we're moving on to things like KPAP. And the idea about KPAP, as you know, is the timing of the therapy. And so now we're getting to a point where we're saying, instead of doing what we think is the best thing, we're getting some feedback from the body to say a biomimetic approach, to say, what is the body doing? What is the breathing behavior? How can we modify that to the patient's benefit? So if you look at it from that point of view, we have those ideas in terms of, you know, how CPAP is going to become more and more precise in the future. We move to the middle area, you know, in terms of surgeries. And so again, the research for surgeries is very diverse, it's very broad. And so now we have to say which surgical procedure will be suitable for this individual. So for example, a study just came out very recently, very nice study. And what it showed is that the effect on these patients with sleep apnea is that a large cohort, maybe 70%, is changed from non-positional to positional apnea after the surgical intervention. And so we have to ask the question is, which surgery would have been a slightly better, you know, choice to say we can resolve the sleep apnea to a further extent? If we think things like hypoglossal nerve stimulation, patients with lateral wall collapse may not be the best candidates for that type of procedure. And so this is where we pick up all the information, start putting it together to say which, protocol we're going to use and what is the justification for them. And then third and fourth, you know, again, not in any sequence, any order, but, you know, think about oral devices. There's such a large number of devices on the market. And so, yes, generically, you could say we have partial expanders, or we have mandibular devices, or it may actually be a combination of both of those to say this patient needs something which is a little bit like non-surgical bimaxillary advancement. And so this is, I think, the crucial part as we move forward is to say, how do we decide which combination of therapies or specific therapy is the most appropriate for this patient? Having done the treatment, it doesn't stop there because we have aging. This patient may respond really well to a protocol initially, but as they get older, how are they going to keep up with, the changes, the age changes? And as a patient gets older, they lose muscle tone, they lose muscle mass, increased risk of airway collapsibility. So things like oral myofunctional therapy, which are doing muscle recruitment to say, okay, let's strengthen the underlying muscles here. That may be one option. And the other thing to think about is new therapies which have the same or a similar idea in terms of long-term maintenance. So I hope that kind of helps just to give an overall view in terms of patient management. And again, I apologize, I came to the webinar a little bit late.
No, Professor Singh, that was very great for the things that you added on to this. Professor Lee, is there anything that you would like to add?
Thank you, Professor Singh. Yes, indeed. I think we still need to collaborate each other. It's because the OSA is a multidisciplinary disease, so we needed to do the interdisciplinary collaboration so as to treat the patient, and because not only treat the symptom but also to treat its complication. So actually, we are a team. Thank you.
Yes, I agree. Thank you.
Okay, I guess that's all for our panel discussion. So I'd like to move on to our Q&A session. So the first question for Professor Lee is by Dr. CJ. And then the question is, what is your criteria has to decide when to refer patients to orthodontists for maxillary advancement, mandibular advancement device treatments?
Okay, it's a very good question. In Chang, the ENT surgeon collaborate with the dentist very well. So for OSAS patient, in non-severe OSAS patients, when they are unwilling to CPAP therapy or poor compliance to CPAP therapy, and have no significant anatomical deformity in the soft tissue hypertrophy, I will refer this patient to our dentist for the mandibular advanced device. So the criteria is number one is non-severe OSAS patient. Number two is poor compliance to CPAP surgery. Number three is no significant anatomical deformity. And the patients, because of non-invasive treatment is always previous to the invasive surgery. So in this condition, in these three conditions, I will refer this patient to our dentist for mandibular advanced device.
Thank you, Professor Lee. Next, I actually have a question for you myself. Now, we all know that OSA is kind of a condition that is being treated by various departments. So, how do you bring all the doctors together to treat this type of condition? Like, how do you know, like, when to refer it to another department, or when do they refer patients to you? Is there a way that you guys kind of collaborate with each other? Can you help us expand on that a little bit?
Okay. Just as I said, I'm not sure that I catch a point, but it seems the OSAS is a multidisciplinary disease. So for the OSAS, the patients need a multidisciplinary team. So for the OSAS diagnosis OSAS, CPAP is always the first line treatment. So we collaborate with the Chessman for the CPAP treatment. And then an alternative is oral appliance. And for some craniofacial deformity, we collaborate with the plastic surgeon or oral surgeon for the craniofacial reconstruction. For some very obese patient, we collaborate with the general surgeon for bariatric surgery. And in this teamwork, we can make some of them together, like combine airway and bariatric surgery, combine intravascular and extravascular surgery, or nasal surgery to improve the CPAP compliance, or nasal surgery to improve the mandibular advanced device. So I think that all can put it together, and we always keep the principle, the non-invasive first. So surgery is an alternative and a salvage treatment. So in this way, we all the team can work together.
Thank you for expanding on that, Professor Lee. Next, our co-moderator, Prior, would like to ask you a question herself.
Hi, Professor Lee. I would like to ask about the PET OSA. I'm not sure about in Taiwan. In case if a child have an early signs of the mouth breathing, should we aware about the OSA or not? And the second question, if you meet a child non-obesity who have the mouth breathing, what you gonna check for their status about the OSA, and what's the treatment that you will offer to their parents? Thank you.
Okay. It's very common for a kid to have a mouth breathing, and the mouth breathing is always the first common symptom of pediatric OSAS patients. And for children with to breathe through the mouth, firstly we will check the nasal allergy by the cap to check the nasal allergy test. Then I will prescribe a scar lateral view to demonstrate whether or not the adenoid hypertrophy and the vegetation. So in these two conditions, usually they will combine together. So I will give the pharmacotherapy and the lifestyle modification to improve or ameliorate the nasal allergy. And then I will prescribe some nasal spray, some steroid spray. They could be helpful to decrease the size of adenoid. So in this condition, medical treatment, I think 40% of patients, they will improve their mouth breathing. So the mouth breathing improve, the snoring will improve, and the AHI will be reduced. But for the patients who have very severe adenoid hypertrophy in conjunction with tonsillar hypertrophy, I will just suggest adenotonsillectomy to treat this patient. So for pediatric patients with mouth breathing is a very important sign of OSAS. So I will do the allergy test and the scar lateral view to show the nasal allergy and the adenoid hypertrophy, so as to decide the ongoing treatment, the medication, and the surgical treatment. Fortunately, the majority of these patients will get a significant improvement and a dramatic improvement after 1 week after adenotonsillectomy. So this patient is very common, and the surgical treatment plus the medical treatment for nasal allergy will get a very good result.
Thank you so much, Professor Lee. And may I ask another about the practice with the panelists? Perhaps we start with the professor there first. about the PET OSA, like what of the treatment that you're gonna give to the patient or the screening? Thank you.
To test the pediatric OSAS, sometimes it's not so smooth or so easy like the test of adult OSAS. So we need to have very experienced sleep technician to do the pediatric PSG. So I would say it's not so easy, but we have very fortunate, we have very experienced of sleep technician, so they can perform the pediatric PSG. And so so you need to take care of the very good for the experienced sleep technician to do the pediatric PSG.
Oh, thank you.
Okay, Prior, please go ahead.
Let me go ahead. Yeah. Because let me share about the dentist experience. Most of the dentists sometimes they don't understand the mouth breather related to the OSA in children. Yeah. And how we can I think there is a lot of evidence about that. But if you talk to dentists, I'm pretty sure that many dentists they don't see the relationship between the mouth breather and the OSA. And do you have any suggestions about that, like how to encourage like to the early detections of the PET OSA?
I think we need to be aware of the mouth breathing. That should be the first and the pronounced symptom for dentists to know it will be just suggest the existence of the OSA in children. I think they need to have some wider education for dentists to know the very evidenced symptom of mouth breathing in pediatric OSAS patients.
Oh, thank you.
Okay, one more question from the there's actually one more question. So from Dr. April, the question is, what is your opinion on tongue-tie frenectomy surgery in developing OSA in infant patients?
Okay. Regarding the frenectomy surgery, the effect in the OSAS, especially in infant patients, I think the issue is very so far is controversial because you know in I will just give you a very extremely example for some very small chin kids. Sometimes we will do the tongue deep adhesion by plastic surgeon to decrease the tongue collapse. So in this condition, if you do the frenectomy, I will say it's good to do when you do the frenectomy. If you want to improve the OSAS, you need to do more about the myofunctional therapy. So if you try to do the frenectomy to improve the OSAS in infant patient or in children, you need to plus the supplement of myofunctional therapy. The single frenectomy, I just thought it to be very helpful in the reduction of the severity of OSA. So my answer is, if you do the frenectomy, you need to do the myofunctional therapy together to get a better result.
Okay, I guess we have one last question. So this question is from Dr. Piyapa, and the question is, do you do DISE in children, and what type of cases do you do them on, and how often do you do lingual tonsillectomy?
Okay. Again, this question is not easy to answer because in different countries, in different culture, the family may have a very different concern about diets in children. And for me, and in Chang Memory Hospital, for those patients in pediatric OSAS patients, when we take a scar lateral view and found or do the fibroscope and found there's a very severe lingual tonsil hypertrophy. In this condition, when we need to identify the real collapse of the lingual tonsil to obstruct the hypopharyngeal airway, I will do the pediatric dice. And I always collaborate one very experienced analgesic doctor so they can give a very optimal sedation to the children. So for me, my answer is yes, I will do the pediatric dice in children to testify or to confirm the hypertrophic lingual tonsil will totally obstruct the hypopharyngeal airway, so as to make the decision for lingual tonsillectomy. Not the tonsillectomy, but the tonsillectomy.
Okay, thank you. Thank you, Professor Lee, for your very educational and very multidisciplinary presentations. We are all learn a lot, and we really learn a lot from all aspects from you, this field of the sleep medicine. We are just only plastic surgeons. We just only a small part in the field of the sleep medicine because according to your statement, the sleep medicine is consists of all different kind of expert in all over the world, and then we hope can try to make one of a common the protocol to treat those patients with the OSA, including the ENT doctor, psychiatrist, orthodontist, even though for our field is a very smaller one is the surgeon, especially for us is a plastic surgeon. Yeah, so we are so happy to have the Professor Lee can lead us to go forward and advance, even just only the little steps. But seriously, very appreciated for all you contributed for this field of sleep medicine as well. So I would like to say thank you again, and I would like to say thank you for all our panelists. Finally, I would like to invite all our audience of the ICC webinar, especially our guest panelist, Professor Susanna, Professor Deb, and Professor Wish to come to show your smile with us. It's our group photo time, okay? So later, I would like to invite all of you to share your screen, and please give me your lovely smile, and I will count to 3, and then I will take the captures.
Thank you.
So I will count 1, 2, and cheese. Yes, that's good. Once again, okay? I will count to 3 again. Okay. 1, 2, cheese. Very nice. And before I close this sessions, any prior would you like to advertisement any the conferences in the future, near future? Hi, prior, please.
Oh, PY, can you open up the sharing? Because I can't open up my PowerPoint. It won't let me share.
Yeah, you can share now.
Okay, perfect. Prior, please go ahead.
Thank you so much, Dr. Cho and Dr. Chunya too. And Thailand will have the sleep conference, CIRA's International Sleep Surgery Workshop and Conference in 2025. And the hands-on just fully booked, but the conference still available, like on January 9 to 10, 2025. And we have like, please change to the next. Doctor, okay. And the highlight topics, we will talk about the what's new in the upper airway evaluation and combining the anatomical phenotype with physiological phenotype. And we also have the presentation from Professor Wilson and Professor Mackey. And who is the for the fans of Dr. Bowan, he will give the presentation at this conference as well. And now the early bird registration is available before November 16, 2024. And about the conference venue, it's a very convenient and you can get there very easily from the airport. So if anyone interested in the SIP conference, please come to join us in Thailand with the Cisco, or you can go to the website cisco2025.com, or you can capture the QR code and see all information. And thank you.
Yes, thank you. Welcome to Thailand. So because this is the second time of my Sleep International Conference. Last time we have before COVID, we have Professor Woodson come to my hospital and with Dr. Narong from Pediatric Sleep from USA. And so we welcome you all to my second conference. This year, the weather is okay, and I think many of Thai food and friends will welcome you. Warmly welcome. Thank you very much.
Okay, thank you. And I will announce our next ICC webinar is 2 weeks later, and we invite Dr. David Chang to talk the topics, the primary cleft lip and part repair. Thank you for all our audience come visiting and come participating this very wonderful presentation from Professor Lee. So good morning and good evening. Have a nice day and have a nice one. Bye-bye. Thank you very much.
Thank you very much.
Bye bye.
Thank
See
you.
you.
Thank you.
谢谢李医师，谢谢教授。Thank
you.
you, Susanna. Thank you, Wish.
Thank you.
Thank you, EK.
Thank you,
Thank you,
Professor,
EK.
everyone.
Bye
Yes.
bye.
Bye.
Thank you. Thank you, Prior.
Thank you.
Thank
you
you,
all.
Junior.
See you
Thank
tomorrow.
you so much. Okay, bye bye.
Bye.